So with my welcoming to you and congratulations, we are proceeding to today's topic on the ECG. So ECG always a topic of learning. This is our institute, those who couldn't see before. And from student to teachers, everybody is to learn ECG throughout their life. Sometimes ECG become very puzzling. So there may be some expertise of the ECG in the world also as well. So it needs round the year and whole life learning process. But the nightmares, what personally I had, I like to share with you here. And very often, and many of you attended maybe in the many ECG courses, maybe very long courses, maybe short courses. But what I will say here, I hope that you will get some difference from them. It is my expectation only. I am not sure. In the day-to-day life practice, as I am a practitioner now, so it's my pleasure and the privilege to share with this. It doesn't mean that we will talk on the ECG everything today. We actually divided the topics in different parts. The today's topic will be ischemic heart disease, the dangerous part of the ECG detection and the management as well. So we may be the doctors here of different levels also. Some are very junior, some are maybe some seniors, some are maybe appearing some post-grade exam as well. So the very common things what we are to face in our day-to-day practice, we will try our best to highlight it. So our main topic will be ischemic heart disease today. In the subsequent classes, hope to be another day with other topic. Maybe 2-3 more classes on it. So we will finish also a little earlier, not very long time we will take today. With some introduction, we like to start here. The normal 12 lead ECG, it is very important. Which is normal is very important. We always learn the ECG type these here, the long, the lead 2, limb lead 2 or 3. When you are asked to draw an ECG in your paper, usually you draw this. Possibly you never has drawn this, AVR. So for technical reason, we are unaware of such ECG, such complexes. For that, I am thinking that we are everybody to be oriented with different types of ECG. That means in the 12 lead ECG, this is very standard ECG. Second thing is that ECG lead may be more than 12 lead also. Beyond the tradition, suppose a patient having or patient will be diagnosed as the posterior myocardial infarction. Usually, this 12 lead ECG directly cannot diagnose it. There is a technique to diagnose from these standard 12 lead, but to detect directly, that means the typical features of the ST elevation to be identified, we need to place a posterior lead. It is extraordinary and additional according to the suspicion. But traditionally, as we know about the 12 lead ECG, so we have to remember it in our mind, this from 1 up to V6. I have written one word here is a reciprocity. Reciprocity means if there are two things, if one thing is up, another thing is down. I will highlight the word later part in subsequent slides. Just keep in the mind the word reciprocity. Fine. I will try to say something here. Suppose if we consider the chest leads, lead 1, 2, up to 6. Now, if you go to the ECG pictures here in the chest lead, you see that the positive deflection is R here is smaller than the negative deflection, that is the S wave. If you come forward from V1, V2, V3, that means if the lead is nearer to the electrical axis, you see this, I am moving the cursor, this is the electrical axis, then it will be more positive, more positive. So in the lead 5 usually will be the tallest, or it may be 4 or 6 also as well, but in general the V5 will be the tallest R wave. Whenever you get the tallest R wave, normally you are getting the S wave down. You can see now here. That means S wave almost no. But if you find S wave in the V1, S wave is very deep. So S wave is deep here, here is very small, there is almost no. 5 and 6. That I mean the reciprocity. The positive word is bigger. Usually the negative waves, that means this, it's I'm not telling the proportionately, for general understanding. We will utilize this message in the calculation of the left ventricular hypertrophy and other also, right? Again, to show you the practically recorded ECG here, 1, 2, 3, 4, 5, that not 5, the 1, 2, 3, the limb lead, then the augmented, right? The limb, right arm, left arm, and the foot, the chest lead like that. So if it is a 1, 2, 3 are the positive, the whole the waves are negative in which lead? This is the AVR, that is this one. This is very, very physiological but normal. If the waves are high up, definitely it will be due to very any other disease. I am requesting today's participant, please, if you don't understand anything, you can raise your hand. In course of the discussion, in the good time, I can give you the opportunity to talk about also. Better not to be only the silent observer. You can raise your hand if you want to know anything. I'm now proceeding. So this is very basic thing, you know, the interval segments and others. Just to knock you, what I was also knocked by myself, to remember the definition, the distance. What is the meaning of interval? What is the meaning of segment and others? You see, this is the interval started from the beginning of P wave and ending at the beginning of QRS, whether to say QRS. Somewhere Q is not available, so it will be rather to say QRS. So beginning, this is the beginning. But in somewhere else, you see, the segment, it is not the beginning to beginning, it is the ending to beginning. That is the ending of the P wave to the beginning of QRS. So if we are not alert about that, when we remember or memorize, it may be wrong. So somewhere from beginning or somewhere from ending of the waves, in very short. So many of you know about that, including the interval, TP, ST interval, and others. Many intervals, many segments are there. This is the QRS duration. QRS duration is from beginning of the QRS and ending of the QRS, right? So very important thing, definitely the PR for the conduction problem. Segment is important for the detection of the ischemic heart disease. QT interval is very important for the arrhythmia, right? So I am proceeding now. The duration measured and the value given here. For your kind information, the values are not fixed throughout all the books throughout the world. There may be some difference, maybe fraction. It's a 0.1, somebody, some book has written, the author written 0.11 or 0.12, but around like that to remember. Somewhere it is 4.2, somewhere maybe 4.0 also. So always there is a gray zone. To be confident, if the usual, the maximum limit is crossed, then we are confident that, okay, this is the abnormality, right? I told already before a little, the waves, intervals, segments, and the complex. So baseline, which we say the baseline, we are telling that isoelectric, we are telling that the elevation. So contrasting with something, this is the baseline. And the baseline is detected by the TP. I think I can go back a little. Is the TP. So this is the T, right? The wave started here, suppose. So from there up to the P. So this, if we connect a line, it will be the TP, and this is the baseline. Above this line, it will be the elevation, and below this line, this is the depression. Important for the TP. So these segments already you have seen in the pictures. Another one important thing, usually not discussed more, it is called the point. Very important is the J point. J means junction. J means junction. Going back again, suppose this is the junction, S and the T junction. Sometime it remains up, sometime it remains down. In general, if we can identify this is the junctional point, whatever it is up or down, it is very usual. It indicates no abnormality, the J point. So how to identify J point, I will possibly show in today's discussion also. Now, can you interact with me here? Just have a look and tell me that anything wrong there in the ECG. Just to say very simply, this seems to be normal or abnormal. That's enough. Who can say? Can you raise your hand, please? Don't worry, you may be wrong, no problem. The Dr. Shakil is ready. Please, Dr. Shakil, what you were thinking?
Sir, it is, I think it's abnormal, sir.
Which you are thinking about abnormality there? Just try to
Sir,
identify. I will show here. Where?
sir, lip, AVL.
AVL. Sorry, this tracing is fluctuating here, right? For that, you are thinking this is abnormal.
Yes.
You are thinking that the fluctuation of the bases, right?
Yes, sir.
Intelligently, you are telling. Let's hear from other. Dr. Ibrahim, please. Dr. Ibrahim.
Yes, I think abnormal also.
This is the reason for abnormality?
No. Also V1, V3. There is some
V1.
elevation.
There is some
V2,
elevation. Yeah,
elevation.
I will
Yes.
address it,
V2.
doctor, later. I am not commenting right now. You are thinking that this is elevation. Be alert, doctor. I will tell you about that. Okay. Dr. Abdullah.
I think it's normal.
This one?
Normal, yes. I
So,
think normal.
doctor, yeah. Someone telling abnormal, someone telling normal. Dr. Abdullah, why you are telling this is normal?
Because, PQRST, in the leads, same, the normal one. I did not see any, no ST elevation, no ST depression, no wide QRS or short or narrow QRS. Times, like periods, segments, normal for me.
Actually, it will be said as J point elevation here. I will show later though, not now. Otherwise, there is no abnormality found. What Dr. Mashiuজ্জামান Shakil said that it is a technical error. You see that this fluctuation, it seems to be atrial fibrillation. Maybe Dr. Shakil is thinking of. Am I right? Fluctuation of the base or the P wave is replaced by fibrillatory waves. We are remembering that. But atrial fibrillation is not diagnosed by the P wave, rather to look at the irregularity of the RR, irregularly irregular. So it's a technical error, fluctuation of the bases. You see, the fluctuation already affected the T waves and other. Dr. Shakil, can you be connected? Targeting you because you raised the issue. you see that this fluctuation happening in the T wave, also many other waves. Almost all the what I say, the marking of ECG, tracing of the ECG is involved with this fluctuation. So this is a technical thing, artifact, rather to say artifact. So this is a normal ECG, 12 lead normal ECG. Thank you all to join with me in the interaction. Now, as a general physician or family physician, or even the specialist also, interestingly, especially in the South Asian countries, most of the specialists practicing family medicine rather the general practice. So for all, I think it is important, if you want, you can make a snapshot from here. What ECG should be known to all the doctors from junior to seniors. Definitely junior doctor must. So from there, very important thing we will highlight. Right. So now to start the technical thing, how to read ECG. Just follow the animation, please. Look at the whole tracing. Look at the whole tracing first. Okay. Then next one. Please, if anyone want to talk, you will raise your hand first. Then you will try to unmute. If you want to talk, raise your hand first in the Zoom system. Then you will be given the mic. Right. So rhythm, first the whole tracing means what Dr. Shakil said, by looking, there is something wrong. It's a very good idea that we are looking a patient, right? General observation. So ECG to be looked in that manner, general observation. And the rhythm, P wave before. Each QRS is a normal. So is a sinus or non-sinus. Non-sinus means the impulse coming not from the SA node. Rate counting, how to count the rate, though it is not the class or of discussion of this today. If you want, you can go through the other classes. Interval, look at the interval, then come to the QRS complex, normal or not. Look at the ST segment, T wave, then final come to an interpretation. This is normal or abnormal. If abnormality remain in the arrhythmia, then think of, is the rhythm abnormalities dangerous or not? I think you know that suppose ventricular tachycardia, ventricular fibrillation is definitely dangerous. Okay. So again, if we come to this ECG, again a quiz to you, please. Can you raise your hand by looking the ECG? Is it normal or abnormal? Anyone, please raise your hand. Can anyone raise the hand? Please look at first, then you decide. Definitely, you must try. Dr. Makavi, please welcome. Dr. Khalid Makavi.
It's normal. It's normal. Normal.
It's normal. Okay, okay. So as Dr. Makavi answered, we can proceed. We are not waiting for others also. It's a normal ECG. Thank you, doctor. Right. So if we give a break, I think nobody have question. We already discussed, interacted throughout the basic things. We will go to the ischemic heart disease now. Okay. To identify the ischemic heart disease, our attention will go to the QRS complex and ST segment primarily. And here, this is the QRS complex. Normal appearance of QRS complex here. 3 small squares, 1, 2, right there, 0.12 second. So I have shown you before, this fraction of the second may be different in different authors. And different types of normal QRS like that. These are called RSR pattern. Small r followed by S. Sorry, this one RS. Yeah. Then again R. It is called RSR pattern. Sometimes it seems to be like that, and it is also normal. Now come to the topic of the territories of the heart. You know, the anterior heart, inferior heart, lateral heart, and the coronary vessels are supplying the territories with different branches of the coronary arteries. We know the anatomy, but we have to identify the abnormal Q waves. Q wave is the hallmark of myocardial infarction. Whenever in the ECG we find a pathological Q, so it is myocardial infarction. When we tell the Q wave is abnormal, this is this thing. Width, we have to consider the width of the Q wave, depth of the Q wave, and the proportionate depth of the Q wave as well. Suppose in these two complex, this is Q. If the Q is more than 25% of this whole length, that means the QRS complex. So length of the QRS complex from here up to here. But from there, 25%, this is the 1/4. Normally, it will be less than 1/4. If it is more than 1/4, it will be also the pathological Q. The number 4 one is usually the Q wave will be absent in V1 up to V3. So if we find Q wave in the lead V1 up to V3, I repeat, if we find Q wave in the lead V1 up to V3, it is also pathological Q. In addition, I like to say, whenever we get any findings, not only Q or any other finding, we have to identify the same finding in corresponding other lead also. It is also called rule of 2. If we get pathological Q in the only one lead, it is not significant. If we find the corresponding another Q wave, abnormal Q wave in the lead, then it will be pathological. Okay. So these are the basic thing. You understood that area and the right coronary artery territory, this one, left anterior descending, and the distal left anterior descending, it is the V3 and V4. Circumflex, right? Again, the posterior V1, V2 tall R, but not Q. I will explain in the later part of today's discussion. It is very interesting, and how to understand it is very easily. I will try my best. So ST elevation, you know, very identified observation in the myocardial infarction, ST elevation MI, but it is also true that without ST elevation also myocardial infarction can happen. The hallmark of diagnosis for the myocardial infarction is the enzyme level. For that, without ST elevation also a patient may have myocardial infarction, but in the myocardial infarction in the acute stage, it is very important to identify the reciprocal change in the opposite lead. Means if you identify ST elevation in the anterior leads, that is the anterior myocardial infarction to be identified, side by side, there will be ST depression in the inferior leads. This is called reciprocal change. Take care of this, please, to identify this. Very important. Suppose this is a myocardial infarction, and you see the 1, 2, 3. This is ST elevation here. 2, 3 AVF, definitely. Inferior leads are there. So inferior myocardial infarction, there is a Q wave also. So what we expect? We expect that there will be reciprocal change in the inferior leads. You see, sorry, anterior leads. You see the V1, V2, V3 like that. If you follow, especially in the V2, V3, we cannot expect that all leads will show everything. So in the V2, V3, you see this is ST depression. So this is called the reciprocal change. In the same patient, suppose if I cover this, the typical appearance of ST elevation. So indirectly, if we find ST depression in the anterior chest lead, it can represent myocardial infarction in the inferior lead also. But you can tell now that the depression of the ST segment may be indicative of the ischemia. Yes, it may be indicative of the ischemia of the anterior leads. That means the anterior heart. But it may be the possible that patient might develop inferior myocardial infarction. So very simply, we can differentiate it also by looking at the enzyme level or by looking at the symptom of the patient, the severity of the chest pain, the difference between ischemia and the myocardial infarction is there. We can talk to the patient, but we are learning, we are trying to learn something in the ECG. For that we are confining here. This is the one way that reciprocal can change to diagnose myocardial infarction to the opposite area. This is the message to be given here. If you come to that anterior myocardial infarction, so there will be the reciprocal change in the inferior lead. You see now. So this is the anterior myocardial infarction evidenced by ST elevation, opposite lead showing the reciprocal change. So again, we can argue that it could be ischemia, yes. Inferior myocardial infarction with anterior ischemia, no doubt, no doubt. But I will actually try my best to guide you how to identify posterior myocardial infarction. For that, I am taking a little more time here. So again, if I cover this thing, that means the anterior leads, we don't know what about happening in the anterior leads, but looking in the inferior leads, there is ST depression. We can think of, according to the clinical scenario of the patient, severity of the chest pain, the natures of the chest pain, only by looking the inferior lead also, we can say there may be chance of anterior myocardial infarction. But you can say that practically we do the 12 leads ECG. You are very, very right. It is anterior and the posterior we are showing. But one term always we are uttering that posterior myocardial infarction. Sorry, I need to go back a little to come to the slide again. Again, go back. Suppose the posterior, the opposite lead will be the anterior lead, V1, V2. So if if we find that, sorry for a little noise. If we find that the anterior lead having ST depression, anterior lead having ST depression, remember please and follow my talk. So we expect that there will be inferior lead ST elevation if there is inferior myocardial infarction. But in some ECGs, inferior myocardial infarction is not visible. It's not visible. There is something hidden. What could be the hidden thing? The hidden thing is there may be posterior muscle, that means the posterior surface of the heart, posterior wall of the heart is in myocardial infarction. As we are not attaching the posterior lead traditionally, the ST elevation is not identified there. So we are getting rather the reciprocal change in the anterior lead. If anybody don't understand, please raise your hand. It's very critical area we are passing now. Please, anyone? I'm showing again the picture. Look at please and raise your hand. Yeah, Dr. Ala Ibrahim is ready. Try to understand here. Dr. Ala, please have a look here. You see, this is the V1, V2, V3. These are the anterior leads. I will give you the chance, no problem. Dr. Ala, be unmuted. So if we find that ST depression here, so in the corresponding opposite lead will be the posterior lead, but we are not attaching posterior lead by tradition. In that case, we may add another lead in the posterior area. It doesn't need extra lead also. Any lead if you place in the posterior area, that means the back. So you will find ST elevation there without attaching also. Suppose you, the doctor, you know it, suppose you are learning today also. But those who are doing this ECG, they are not that much oriented that in such cases, they have to take another lead record. So to overcome the problem, there is a method of the flipping here in this ECG. Just to look at. The flipping means to look the opposite part of the heart. This is the way. Okay. And it is usually associated with the inferior and the lateral wall myocardial infarction. It is found due to the coronary artery distribution. Dr. Ibrahim, do you like to ask now? Please be unmuted. Yes.
Yes, clear now. Thank you,
Clear
sir.
now? Okay, good. Thank
Yes.
you. Thank
Thank
you.
you.
So I am also showing further. This is the message given to you. It is called the mirror test, and how to do it. Just flip the paper. It was as such. If you turn it up, so it will be shown as such. So the inferior will go up and identify some abnormalities. You see, you got now the Q wave, ST elevation, and the T inversion. 3 features are here. If you flip it, flip means actually you are looking at the posterior surface of the heart. So now read those leads flipped over. 3 questions. Are there significant Q waves? Is the ST segment elevated with a curved appearance? Curved means concavity upward like that, like a cap. Third one, are the T waves inverted? If we ask 3 questions, may I ask anyone who can give the answer of 3 questions here? Who will raise the hand? No one? Dr. Abdullah, can you give the answer?
Yes.
Is the 3 features are evident in this one? When we flip the
Actually,
paper?
for the Q wave, it is there. There is Q wave
Yes.
more than the 25%.
Definitely.
There is Q.
By look, this is abnormal, no doubt.
Yes.
And then?
And there is ST elevation also.
Yes.
With concavity, concave shape.
Convex upward. It is convex upward. That is the curved. It is called the curved ST elevation. And then the T wave, if you go to the baseline, yes, if you go to the baseline,
T wave is inverted.
Inverted. So all together, if the 3 features are there, we are more confident that this is posterior myocardial infarction. This is usually a challenge in the ECG, no doubt. Okay, so this is yes. Thank you. Thank you, Dr. Abdullah.
Thank you.
So to add now, if we find the V1, V2, V3 ST depression, there may be 3 possibilities. One is the reciprocal change of the posterior myocardial infarction, or there may be the concomitant anterior ischemia, reciprocal change of the inferior myocardial infarction, and only the reciprocal change for any other anterior surface myocardial infarction. So reciprocal change for the posterior infarction, reciprocal change of the anterior infarction. Sorry, not inferior infarction, rather, not anterior infarction. I like to clear my word also again, if it should not confuse you. The opposite surface is, you understand, anterior to the inferior or anterior to the posterior. So very simply, if you find any elevated feature in the anterior surface, you will get the depressed feature of the ST segment in the opposite side. This is the thing. So these are the 3 headlines mentioned here, but any combination also can happen. I think this is a very hard area before for me also to understand when I was learner. Learner means I am throughout my life, I am learner when I was junior. Now look at the picture, everyone, please. So question is that acute inferior myocardial infarction with the reciprocal change or posterior MI in this is a live ECG recorded from a patient. Who can say now? Anyone can try? Dr. Ibrahim, please. What do you think? Be unmuted, please, Dr. Ibrahim.
I think there is ST segment elevation in lead 2-3 AVF.
To lead 2-3 AVF. So it's the inferior myocardial infarction.
Myocardial infarction, yes.
Yes, inferior myocardial infarction. Then the anterior lead can show, that means the chest lead can show the reciprocal change.
Yes.
So by rule, it may be the reciprocal change. But I told before also, there may be combination of inferior myocardial infarction as well as posterior myocardial infarction. Is it possible that it could be, in addition, posterior myocardial infarction? What do you think? You muted, doctor. Be unmuted. Anyone, please feel free to talk. Otherwise, I don't know, possibly you are more oriented in ECG, so you are silent. Good. Let us see now. The three features. Flip over, then check. If I asked anyone, doctor, please, I will actually feel better if you can come to the discussion. Who will talk? Dr. Abdullah again. Dr. Abdullah.
Yes.
Can you see that?
We-
Here, V1, V2, all the three features satisfied here?
Actually, the Q wave is not there.
Q wave is not there. If you flip over, suppose the V2, so this one will be the Q. You see? There is a R
yes.
here. So it is said that the tall R in the V1, tall R in the V1 will be suggestive for
Q wave.
posterior myocardial infarction, maybe. Tall R in the V1. So it's a relatively big R here. It is a down. If you flip over, there will be a ST elevation.
ST elevation, yes.
There will be a ST elevation.
ST elevation.
And if you come to that, make a isoelectric line from here.
Yes.
From P to T. Where is the T? Will it be down or up? Seems to be. Now this is up.
Down.
Now this is up. If we flip over, it will be down.
It will be down. Yes.
So there will be a pathological Q. There will be curved up ST elevation. There will be the T wave depression. All three features added. So this is inferior myocardial infarction with posterior myocardial infarction.
Plus posterior also.
Yeah, is a plus. Is a plus. Right. Thank you, Dr. Abdullah. Thank you. So I think that if any doctors are well concerned or conversant about identification of the posterior myocardial infarction with knowledge, he is very, very able to diagnosis of myocardial infarction of any other territory of the heart. This is my belief. For that, I have concentrated more here. Okay. Now the quiz again to you. Obviously, you can answer now. Is it normal? Possibly you will say it is a normal. Already someone said before, this is a normal. Normal minimum in concept of the ischemia. So there is no other features of the block or the arrhythmia also. So doctor, possibly someone be confused about this ST segment. So come there now, maybe later. Again, the question, this is myocardial infarction or not? Someone who said here before that there is ST elevation with some confusion. You can see anything. Is there any ST elevation? Who can say? If it's a ST elevation, so it could be myocardial infarction. Can you check? Don't feel shy. Yeah, Dr. Shakil, please.
Yes, sir. I think it's
Which lead? Which lead?
Lead AVF, lead
AVF, AVF. Let us see. This is AVF. Yes, it could be. It could be.
Yes.
So if you think that it is AVF, means this is a myocardial infarction. What is the appearance of this ST elevation? This is the curved up or curved down? Curved up means like a cap. Tupi, like a cap.
Okay.
Is a cap like, or what I say, the boat like?
A boat like it is.
Boat like. So it is not cap like. So
Yes,
it is
sir.
actually against the features of the typical ST elevation in myocardial infarction. But yes, there is a ST elevation. We cannot rule out by ECG only that it is not myocardial infarction like that. We cannot say. Anybody else can join with Dr. Shakil to discuss this. So if there is ST elevation, we expect that there will be the anterior lead could have ST depression. right? There may be ST depression, right?
Yes, sir.
But there will be T wave up in the V1 also if you identify the posterior MI. So it may be associated inferior ischemia also. So now you see that how the ECG may be confusing to us. For that symptom is very important, not only looking the ECG, right? So
Yes, sir.
what we identify is there a very exceptional thing. There are ST elevation in many leads. Suppose you see the lead 2, lead 3, maybe in the anterior lead, in the chest lead, maybe confusing also though. So we cannot confidently say that the coronary vessels of that right coronary, left coronary typically involved according to the territory. 2, 3 ABF, 1 AVL, V1 to V6, not like that one thing. Another thing is the, what I say, the typical ST appearance, ST elevation appearance. This is not coved up. For this reason, it may not be myocardial infarction. So clinical evaluation also important. But you know that if this is the pericarditis, patient can have chest pain. So we must know about the clinical symptomatology difference of chest pain for the myocardial infarction and chest pain for the pericarditis. The postural change will be there anyway. So one way is the differentiating point like that. Another is the enzyme level, that the blood test for the heart muscle damage. So this is the pericardial inflammation, pericarditis. It is called the chair-like ST depression. ST elevation, chair-like. Okay. And if we find, or not only the lead one, suppose if it is the myocardial infarction due to muscle damage of the heart in the inferior lead, so we can expect that the corresponding reciprocal change in the chest lead, that means the V1, as it seems to be the T inversions and as well as the ST depression seems to be, but here you see that in the V2, it is a typically upright. T wave and ST segment not depressed. So the V1, V2, I told you rule of 2, the two leads are not same. So this is not a significant finding. It means this is not reciprocal change, indicating the myocardial infarction of the opposite surface, that means the inferior wall. So in that sense, this is pericarditis. And another important finding also you will find, it is called the PR depression. If you look at, very suggestive for PR depression, I like to mark here, if you follow me here, PR. It is a little down. ECG is like that, and we cannot make the slide bigger. So somewhere you may find PR depression. What will be the baseline? Baseline will be the P and the T. If you make here, suppose, it's a practical ECG is very difficult to make. From the beginning of the T wave and from the beginning of the P wave, if you make a line, if anything below, anything down, this is down. So you can find here also the PR depression. So it's very suggestive for pericarditis. PR depression. Remember it. Another less significant and less common thing, atrial infarction also causes PR depression. But by practical situation, remember PR depression is a marker for pericarditis. Okay. It is non-territorial. ST elevation is non-territorial, rather haphazard, general. So now come to some exception here, doctor. The myocardial infarction is, again, our confusion is the myocardial infarction or not. If we see here, you see this is ST elevation. So is it myocardial infarction? Who will say now? Is it myocardial infarction? Dr. Abdullah, please unmute. Please unmute.
Actually, maybe we have to see symptoms also, and there is ST elevation, but maybe it's MI.
Maybe you are thinking, okay, I'm telling that patient does not have symptom. So even then we can say this is ST elevation. Here also, here. What do you think? Anyone can share, please?
Actually, I think it's MI because there is a clear ST elevation.
Okay. Anybody having any doubt? Dr. Ahmed. Dr. Ilfateh Ahmed, please.
Yeah, it's there's elevation, but I think not MI. Maybe hyperkalemia or
Hyperkalemia will be the peak T, doctor, usually more than the R, usually. So there is no hyperkalemia, but why the ST is elevated here? This is the question. And it is the confusing, even in the junior doctor like me, what I was before. I was thinking that this is myocardial infarction. So I like to share with it. I told you one word, it is called the J point. Can you remember, Dr. Fatih? J point elevation. This is the J point. Can I mark here another one? This one. Sorry, doctor, my writing is not good. Here, this point. J point. Point between, junctional point between the ST segment as the S. Right? S wave and the ST segment. This is the J point. If it is elevated, it is called the early repolarization. This is physiologic. This is the normal variant. Okay, Dr. Fatih?
yes.
It's very critical. If you understand, it's my pleasure, doctor. You see, most of the ECGs, patient does not have chest pain. So it is called the J point elevation or early repolarization. As I told to the response of Dr. Abdullah, that if patient does not have chest pain, one thing, it is not myocardial infarction, but it could be myocardial infarction ST elevation also. Even then, patient does not have the chest pain. As a clinician, we know if patient is diabetic, there may be neuropathy. Patient does not feel the pain also. Elderly patient.
Yes.
On that time, what could we do? Not only by looking the chest pain, we have to be able to identify the ECG also. If it's a clean cut like that, it is ST, not pathological ST elevation. This is ST elevation, no doubt. It is called the early repolarization. I like to add here something. To be confident, though I will not show the picture to you, just follow me. This is the T wave. If you are asked, is the T wave started very clearly or not? That means the definitive point of T wave is not there or not. Yes or not. Suppose if I mark here, follow me. So we can say that T wave started from here. That means there is a point T wave. But if this distinction is lost, the ST segment and the T wave we cannot separate. If I draw here, one doctor said that hyperkalemic, right? Hyperacute MI. Can you remember hyperacute MI like that? Am I right, Dr. Al-Fateh? Can you raise your hand? You told me before possibly. There is no distinction of the ST elevation and the T wave. It is the hyperacute MI sometime like that. So if the T wave cannot be separated, it is MI. If the T wave be separated from the ST segment, separated means I can identify the separating point. This is also in favor of J point elevation. That means it is not the J point, point is here, but additional feature of connecting point between the ST segment and the T wave. It is also additional feature. I think this is all for understanding. Dr. Fateh, yeah, please. Any addition from you? Do you understand? Dr. Al-Fateh?
Yeah, it's clear.
Clear now?
Thank you.
Thank you. Come to the other part of ST elevation here. It is not myocardial infarction, but ST elevation is there. It is called the Brogada Syndrome. These are the features. You can make a snapshot, doctor, so that we can save our time. I am reading from the picture. This is also echoed up This is also curved up, right? ST. Though there is a no Q wave, you understand it is not myocardial infarction. But Q wave comes little later. It is also true. So without Q wave ST elevation, only lead 1 and lead 2. So these are type 1 Brogada, type 2, type 3. Is not too much common, but very common in the academic exam, in the post grade, for that I am telling here. So this is the description, doctor. So symptomatology is important. Patient does not have chest pain, but patient have history of arrhythmia. Patient may not have arrhythmia in previous time, but patient may have family history of arrhythmia. This is the Brogada syndrome. Again, you are invited to raise your hand if you don't understand. Remember the Brogada syndrome. The type 1 is well accepted throughout the world. So there may be some type 2, type 3 also described, but this one is very important. Commonly, ST elevation here. Okay. Now the question, this is MI or not? Patient does not have chest pain or have chest pain, we do not know. By looking the ECG, who will say? Please look at asking MI or not, not asking arrhythmia or anything. Can anyone say? You see that there is elevation. Is it clearly visible? There are elevations, elevations, 3, 2 not clearly visible. If you come to that, the inferior lead also, 2, 3 ABF seems to be up. So Dr. Shakil also telling something. Please, Dr. Shakil. This is also MI or not?
This is MI, sir.
This is MI. You are thinking that this V3, V4, V5, right? V4 here, V5, V6. Yes. Okay. Any other comment, please? Don't feel shy. Dr. Abdullah wants to say? MI or not?
Yeah, it's MI, anterior-lateral.
Anterior-lateral MI. One AVL also there, doctor? Lateral, maybe 5, 6 for that you are telling. If it is supported by the one AVL, so we can say that it may be anterior-lateral MI. So there is no ST elevation in the AVL, right?
Yes.
So if we want to say this is MI, we need to search for the reciprocal change. Dr. Shakil and Dr. Abdullah also. If you try to say that this is myocardial infarction in the anterior surface, we can expect that side by side, the ST depression in the inferior leads. Shakil.
Yes, sir.
So can you find any 2, 3 AVF ST depression here? Can you see?
2, 3.
AVF, 2, 3 AVF, no ST depression.
No.
No ST depression. And this is a long lead 2. I'm mocking. It is not the 2. It is only long lead to see the arrhythmia. So everyone, please have a look. There is no reciprocal change in the 2, 3 AVF. So these ST segment elevation may not be, usually not be representative for the acute MI right now. It may be the persistence of anterior MI earlier. So without reciprocal change, what could it be? Suppose patient was having myocardial infarction before. What could it be? Left ventricular aneurysm. This is a recognized complication of the myocardial infarction. It means previously patient was having myocardial infarction. Infarction is over. So reciprocal change also over. Lately, this complication developed and the ST elevation persisted, not being at the baseline. This is called the left ventricular aneurysm. So aneurysm is there, ST elevation is there. And this is the area for the arrhythmia development. So consequence is also bad here. So another ST elevation you have seen that it is not myocardial infarction now. Another ECG. This is a MI question, please. Yeah. Sorry, doctor, I cannot read Arabic well. Dr. Abdullah can read. You can say your name, please. You can say your name, please. Huh? Good to see
Yes.
Arabic.
Yes.
Doctor, please, can you tell your name, please?
My
Ah,
name?
you mean
Yeah, please tell your name by yourself. Who raised the hand?
yeah, this is actually Dr. Yahya.
Yahya, I
I'm
understand.
sorry, I think it's written in it's written in Arabic. I'm sorry for that.
No, not sorry, doctor. I'm very pleased and happy because
Yeah,
I'm oriented in Arabic, but I
thank
cannot
you very
understand
much.
sometimes.
Thank you very
You are from, doctor?
much. I'm really enjoying it. I'm
You are
from
from?
Sudan, actually, living in
Yeah,
UAE.
your
Sudan,
tone is
living in
telling,
UAE.
your voice tone is telling you are from Sudan. Thank you, doctor. No problem.
Ah, welcome,
What do you
welcome,
think, doctor?
welcome,
Now,
doctor.
this is myocardial infarction?
Actually, I'm not seeing reciprocal changes, actually. I think maybe it could be left ventricular hypertrophy sometimes, because
No, we are not discussing
it's
actually hypertrophy today, even though we are searching for ischemic changes, myocardial infarction or the ischemia. Suppose we are searching for the ST elevation today here. You see, this is ST elevation. Sorry, there is some
yes, yes.
noise. Take care. Take care.
So,
Okay. You see that the ST elevation is there. Which lead, Dr. Abdullah, can you help me? Answer my question, please. V4, ST elevation?
Yes.
ST elevation.
V4, yes.
Is there any
Yes.
ST elevation in the V3 or V5? No.
No. Only
Again,
V4.
only V4. Again, if we consider the V4, is it that clean cut ST elevation curved ST elevation? No.
No.
Right? No. So this may be J point elevation. You see the T wave is started from here, from the very specific point, right? It is not abolished. It is not abolished. So it cannot have the typical criteria for the ST elevation for myocardial infarction. This is one thing. Second thing is these elevation only present in the V4, not in the V3 or the V5. That means the subsequent. So it is also not in favor. It is also not in favor.
Because it's only one lead.
Only one lead. So if it is only one lead, and you see there is other leads also not having ST elevation, typical ST elevation, can we say this is myocardial infarction?
No.
Dr. Yahya also now, if you are relaxed, you can say no. So what is the finding? If it is no, there is also one ST elevation. Side by side, T depression is there, 1, 2. It may be normal also. T inversion in the V1, V2. Dr. Yahya, is it MI?
No, I don't think it's MI.
MI. It is called non-specific STT changes.
Non-specific. Yeah.
It's very common, right? Those who are seeing the patient in your practice also. It's very common.
Yeah, I saw many times like this.
Yeah, like you and others also, anytime. So we will be worried. A junior doctor may be worried. Oh my God, there is a ST elevation. Yeah. So I believe that this class definitely will be helping for them. Okay. So
well, that's why, doctor, sometimes it's very difficult to differentiate if there is another cause for it. For example, I gave explanation for that in left ventricular hypertrophy.
Yeah.
Sometimes you see it, an aneurysm, as you said, also.
Yes.
And in left bundle branch block also you see.
You are right, doctor. But for that, we are the doctor clinician. We are not treating the ECG, right? We are treating a patient.
Yes.
So to talk to the patient, examine the patient, plus do the enzyme test. And a patient should not be left alone without evaluating the enzyme and the symptom, only by looking the ECG, right? For that, we have to go through. But from the ECG, if there is a typical feature, we can say that, yes, this is a typical feature of myocardial infarction. Okay. So we will be finishing, doctor. Don't worry, after a few minutes. Now come to a few things about the ST depression. This is the ischemia, features of ischemia, ST depression. There is also the J point issue. In the myocardial infarction, J point elevation. In the ischemia is the J point depression. It can happen in the ischemic feature. So 1, 2, 3, 4, 5 picture I have shown. Be clear about. There are ST depression. This is the normal ST. This is, you see, J point down. It is also normal. Up sloping ST, I will talk more on this. down sloping as well as the horizontal ST segment. So this is a very, very characteristic ischemic feature in the ECG, more than 1 millimeter here. But in the upsloping, this is also depression. Most of the time, this is normal, but there is some hidden information. If the 1 millimeter depth, that means down, if it is in the 3 or 4 small square, that means if you start from here, ST, 1 and 2, this is the second, this is the third. So if you come up, so in the third square, there is no ST depression. Am I right? Dr. Abdullah, can you see? You can echo with me, doctor. You see 1, 2, 3. 3 a small square. If you go up, in this point,
Yes.
there is no ST depression.
There is no depression, yes.
Yes. But if the ST depression, we say it is in the end of the 2 small square, 1 millimeter ST depression. Suppose if this ST depression, I'm drawing a line, doctor, follow me. If it is like
Yes.
that, could it be ST depression pathological? Yes.
Yes.
Yes. This point 1 millimeter down. So this is the hidden information here, that sometime in the book it is written the upsloping ST depression is not abnormal, but there is some extra information, what I shared with you now. And
Yes.
usually this data is utilized in the ETT also, exercise tolerance test ECG. If we are confused, okay, go for the investigation, do the ETT or go for the echocardiogram or the angiogram, depending upon the background. If the patient is diabetic, hypertensive, smoker, then it can give an idea that it may be ischemic. But if it is a clean cut like that, it is not ischemic, it is true. Clear, Dr. Abdullah?
Yes.
Good, good. Now just few words on the ETT, exercise tolerance test, and many names are there. Is the appearance. Sorry, Dr. A also, you raised the hand for that. I'm inviting. If you want, you can talk also. So these are the contraindication as a clinician, not to send for the ETT, remember. Make a snapshot, please. I will not read. Very common things, we must remember it. Severe stenosis, remember what the severe. Arrhythmia, untreated arrhythmia. Hypertension, uncontrolled hypertension. Not all hypertension. And the value also given here. Please try to remember. Even after myocardial infarction, within 4 to 6 days also, exercise tolerance is not done. I'm sorry, this picture is not much clear. That is the thing I discussed, Dr. Abdullah. I think you can see also on behalf of all of you colleagues today.
Yes.
If it is 1 millimeter down, beyond 3 small or 4 small, somebody said it is a 3 small square, somebody say 4 small square. For that I have written, suppose if it is the below the 4 small square, nobody will argue. If it is a 3, some author will say no, it is normal. But if it is the 4, 1, 2, 3, 4 like that, 1 millimeter down, it is positive. For that, sometime the ETT, the doctor doing the ETT, cardiologist can tell it is equivocal ECG. So equivocal means opinion is not clean cut. This is negative ETT and this is definitely positive ETT. And the limitations of the ETT is sensitivity is 68%, specificity 77%. Please try to understand the word sensitivity. Specificity is a statistical word. I am not here to explain now, is another topic. But the false positive result can happen, right? False positive result. No diagnostic value if there is LBBB, pace rhythm, and the WPW syndrome. Try to remember. If some of you possibly follow such patient, not everyone, as a GP, as a family physician. Now, the ST depression other than ischemic heart disease. This is the digoxin effect. You see, down sloping. Immediately before you have seen down sloping is pathological, but this down sloping is not pathological. Pathological means it is not indicating the ischemia. It is indicates the digoxin effect or toxicity. There are two words. One is that the toxicity, another is the effect. So the reverse check or the reverse tick sign of digoxin effect depends upon the position of the T wave. I will show you in the next slide. You see, this T wave is above the baseline. So the picture A showing reverse tick sign, terminal positivity. In the B is a baseline near about or little high, but in the C, it is completely down. That means I am telling about the T wave. So in the C, the clean cut down. If the T wave is clean cut down, digital is toxicity. If it's a confusingly down, rather, the C is above here, you see, seems to be baseline or relatively down. You may argue, you may debate, okay, skip it. But what about the A? Is definitely T wave is up. So T wave is up means it is digoxin effect. Is T wave is down means digitalis or digoxin toxicity. But both are having ST depression and the downsloping. So we need to have the history of digoxin digitalized patient, patient taking the digoxin. So interesting thing is that the ischemic heart disease patient have arrhythmia, heart failure, we are giving digoxin. So things will be complicated. So better to avoid the complication today, just to learn ECG, digoxin effect. What is that? S wave, R wave in the AVR. If patient take the TCA, tricyclic antidepressant, toxicity ECG feature is like that. There is also, you see, ST elevation. ST elevation, this is R wave, right? So confusing sometime ECG like that. If the VT is there, only the QRS complex is there. Very difficult to identify, but by look, it's very easy to identify the ventricular tachycardia. So TCA toxicity causes ventricular tachycardia like that. So in the AVR, very important here, but in the book, it is written, this one, lead to this appearance, ventricular tachycardia. So in the meantime, really, I have shown a little uncommon, rather to say, for understanding only that how could it be. You see AVR. Usually AVR, all the waves are down, here up. So this is TCA toxicity. Finally, now, before the ending though, the normal findings in the healthy individuals, requesting to take the snapshot, doctor, if you feel better. All findings are individually isolated situation. It may be normal without any clinical history and everything. It may be normal. So you may find very common things are here. There may be some uncommon issues also. But the block feature also, when Quebec phenomena and other junctional rhythm, first degree heart block may be normal variant. ST segment elevation, we talked about the J point elevation, high takeoff or early repolarization, all are normal. Yes, doctor, the last slide. Nowadays, junior doctors especially, sometimes we are very fond of looking at the machine report, automatic computerized report. So these are the drawbacks of the computer generated reports. Please make a snapshot. I hope that you will understand by yourself. Okay. And thank you very much. If you have a query, doctor, you can raise now 1 or 2 minutes. Please don't leave.
Thank you, sir, very much.
Dr. Ibrahim, Allah Ibrahim. Please, Dr. Allah Ibrahim.
I confused only about pathological Q wave. Can you help me?
Which one, doctor?
Pathological Q wave.
Pathological Q wave. Oh. So, doctor, give me a chance to go to that slide. Maybe in the first few slides there. Yes. Can you see now? Doctor?
Yes, I can see.
These one, the characteristics, very simple, pathological Q wave. Okay. Okay, doctor. Do you need explanation from here?
No. These four items will be characteristic. Yes, appear now. Thank
Okay.
you.
Okay, doctor. So if no more, we can end now, doctor. And thanking you for your patient hearing as we prepared this for you, really for your benefit. If you feel better, we can arrange the next class also.